Dr. Kirsten Luber is going to be graduating in a week from preventive medicine residency and then starting her transgender medicine fellowship upcoming. We're very excited to have her talk to us about HIV prevention as well as intimate partner violence and other STI prevention.
My name's Dr. Kirsten Luber. Pronouns are she, her. I'm talking today about preventing HIV, other STIs, and intimate partner violence. To sort of set the stage, today we might be talking on some potentially sensitive topics. We all come from different backgrounds, different experiences, so I want us all to be aware of that. Since these topics can be potentially triggering for some people, feel free to excuse yourself if you feel uncomfortable. That's not the goal here. So a little bit about where we're going today, just in general, what is harm reduction, then some information about HIV, how to prevent it, a couple different ways, as well as where to seek medical care if there has been a potential exposure or you've been exposed, how to go about that process. Talk a little bit about how to prevent other sexually transmitted infections, or STIs as I'll call them going forward, including some really interesting research that I'm particularly jazzed up about for STI prevention. And then at the end, we'll touch on intimate partner violence. What is harm reduction? This is a philosophy within public health aimed at essentially trying to minimize the negative consequences of certain behaviors, not necessarily trying to change the behaviors themselves, but trying to reduce the harms associated with those behaviors. So it kind of accepts people more so where they are rather than trying to change their actions, but still trying to keep them safe and keep them as healthy as possible, acknowledging that those actions may continue. So there's some principal tenets associated with harm reduction. Number one, it accepts that drug use is part of our world, as well as focuses on the harms rather than the behavior itself. So we're really just trying to keep people as safe as possible, acknowledging that certain behaviors may continue. It meets people where they're at. It prioritizes health and human rights, really centering the person or the patient that you're trying to help. And it empowers individuals to improve their own health and well-being, really a partnership between the person or patient, the provider, the case manager, social worker, whoever is engaging in that harm reduction process with that person. It is evidence-based. Research has shown that harm reduction protocols are effective at what they do. The goal is being to reduce harm associated with behaviors, not necessarily change the behaviors themselves. And really importantly, it is a collaborative and community-focused effort. Going back to that partnership, really trying to team up with people and help them to stay as healthy as possible. Harm reduction is a human-centered approach to public and individual health. It can be applied to larger groups of folks as well as the individual person. And specifically, there's two behaviors that it is readily applied to, but it can be applied to a lot of different situations, specifically drug use as well as sexual health behaviors. And some examples of harm reduction for drug use include needle exchange programs, making sure folks have clean needles, supervised consumption sites to reduce overdose, opioid substitution therapy like methadone, as well as education on safer drug use. What we'll be focusing on today is the sexual health behaviors and how to reduce harm associated with those behaviors. So that includes certain medications to prevent STIs, specifically PrEP and PEP. I'll go into those a little bit later. Providing access to prevention methods like condoms, medications. You can't really employ these prevention methods if you can't access them. It also includes testing for and the treatment of STIs, specifically without judgment. That's really key to harm reduction. We don't apply judgment to anyone. And again, education on safer sexual practices. Try to empower the person to help reduce harm. And this little graphic, I really love it. It says that harm reduction means respect, dignity, and compassion. Again, really centering that person that you're trying to help. And very important, harm reduction is not really effective at all if there's judgment associated with it. So everything that we do, we just try to help people stay healthy and stay safe. So it's very much a judgment-free zone. Shifting into the bulk of what we'll be talking about today, HIV or human immunodeficiency virus. So just to kind of level set, HIV is a virus that attacks the person's immune system, specifically CD4 cells, which are cells that help fight off other infections. So if someone has HIV and it is untreated, uncontrolled, then they're at higher risk for other infections. In certain instances, this can lead to something called AIDS or acquired immunodeficiency syndrome, where basically there's what are called opportunistic infections that healthy people with fully functioning immune systems wouldn't get. So that's a handful of infections that sort of triggers a doctor to think that someone may have progressed from just HIV infection to AIDS. However, HIV is manageable with medications, but not yet curable. People with HIV can live normal span, very healthy lives with the help of medications. And early detection and prevention are key in keeping HIV rates from climbing and keeping those who do have HIV healthy. And I do want to draw attention to this little picture on the side, U equals U. That's the saying within the HIV world that undetected equals untransmittable. So basically that means if your HIV viral load is suppressed, you cannot pass that to anyone else. So again, it's a very manageable disease, can be managed quite well with the current medications that we have. We've come a long way since the HIV/AIDS epidemic of the late 80s, early 90s. So how can it be transmitted? Specifically and most often through body fluids, often exchanged through sexual contact or needle use, specifically blood, semen, vaginal fluids, anal mucus, but it can also be transmitted through breast milk. And the needle aspect includes both intentional needle sharing, like through drug use, but also accidental needle sticks. That's kind of more impactful for healthcare workers, like in the hospital setting. And I did want to mention some common misconceptions about HIV as well. All of the things listed here are incorrect, but I know misinformation, disinformation is running rampant these days. You cannot get HIV from a blood transfusion. We screen blood products very heavily. Gay, straight, non-binary, gender non-conforming, anyone can get it. Anyone with an immune system can get it. You can't tell if anyone has HIV. There's no really outward signs. Mosquitoes cannot spread it. Nope. And sharing eating utensils, that's not a way to spread it at all. Similarly, kissing can't spread HIV. And I kind of touched on this before, but HIV and AIDS are not the same thing. They're pretty distinct medical entities. And again, getting HIV is not an automatic death sentence. We can do a lot as far as treatment, prevention, and helping manage this condition. So first and foremost, how do we prevent HIV? There are a lot of different lifestyle choices, kind of behavioral aspects to preventing HIV. One really big one and really effective one is using condoms during sexual encounters, and that includes all sexual encounters. Penetrative sex, vaginal or anal, receptive as well, oral sex, using condoms in any sort of sexual contact can really reduce the risk of HIV as well as other STIs. And it's important to use condoms correctly as well. There's instructions. I know nobody really reads the instruction manuals these days, but using condoms correctly is really key to helping prevent risk of all sorts of sexually transmitted infections, including HIV. One way to limit your potential exposure to HIV is limit the number of people that you are engaging with as far as sexual behaviors. Avoid sharing needles, because again, any sort of blood product is how HIV is commonly transmitted. And really important, talk to your partners about their HIV status. You don't know what you don't know. So if you're engaging in these behaviors with someone and you're not sure of their HIV status, it's really important to talk to them, have an open conversation, just so that you know the risk that you're potentially taking on with those behaviors. And then get tested, know your own status. I'm a big believer that knowledge is power, and you can't really act on information that you don't have. So talk to people that you're engaging with in these behaviors, and then know yourself as well. Kind of transitioning to the medication side of things, how can we prevent HIV? There's two different ways. One is PrEP or pre-exposure prophylaxis, and one is PEP, post-exposure prophylaxis. So the difference between those two is that for PrEP, the pre-exposure, the person does not have HIV. And this is really prophylactic, really preventive as far as getting HIV. And then PEP, post-exposure, the person may have been exposed to HIV, we're not sure, or we do know that they were exposed. For instance, say in the hospital setting, someone is treating a patient, a nurse is treating a patient with known HIV, and they're drawing blood, they accidentally stick their finger. We know that that nurse has been exposed to HIV. So in that instance, that nurse would go for post-exposure prophylaxis because we know there was the exposure to HIV, but we're trying to prevent the nurse from then getting the infection itself. There's a window of time where after someone is exposed to HIV or potentially exposed, that this medication is really effective at preventing the actual transmission of HIV. That has to do with how the virus replicates, but that's a talk for a different time. So a little bit more about the difference between PrEP and PEP. So just kind of focusing on the left, the pre-exposure prophylaxis or PrEP. This is a medication taken every day before possible HIV exposure, and you continue it as long as you might be exposed to HIV. I've worked in PrEP clinics, and we've had patients on PrEP for many years because they just want to reduce their risk of HIV. And that's perfectly safe. That's perfectly fine. And there are these pink arrows. These are some really great resources within the New York area for where to get PrEP or PEP. Looking at the PrEP side, the left side, there's a phone number that you can call to get linked up with doctors who prescribe PrEP and how to start that process to get that medication. And PrEP is for anyone who does not not have HIV and wants to reduce the risk, be it they know they may be exposed or they think they may start to engage in behaviors that could increase their risk. PrEP is really available and appropriate for anyone who wants to reduce their risk of HIV. And then transitioning to the post-exposure side, PEP is very different than PrEP. It's an emergency medication, not taken every day. It's only taken within 72 hours of an HIV exposure or potential HIV exposure, ideally within 2 hours of exposure. The sooner that you get started on PEP, the more effective it is at preventing HIV. And this is a much shorter course of medication. It's 28 days. So you take it daily for about a month after your HIV exposure. And it has very high rates of reducing risk of you actually getting HIV if someone is exposed. And then again, looking down at the pink arrow, we have a New York City PEP hotline. Basically, you can call that number, figure out where you can get tested for HIV, and then figure out how to get the medication. So PEP is also for people who do not have HIV, but may have been exposed. So the testing aspect is really important for PEP, for the post-exposure prophylaxis, because we can only start this medication if we know someone is HIV negative. The reason for that is that if someone were to what's called seroconvert or basically acquire HIV, this medication is no longer effective and they need to start HIV treatment medications rather than preventive medications. And that's really important for making sure that the medications that we do have remain effective at treating HIV and we don't develop what's called drug-resistant medications. So a little bit different with the PEP that does involve an HIV test. Short course of medication needs to be started within 2 to 72 hours of exposure, whereas PrEP, you can take that every day for many years and it's more appropriate for more people. So thinking about where you might look for resources, if you think you may have been exposed, if you're unsure, if you know you've been exposed, there's a lot of different resources around the city. Where can someone get HIV tested and PEP in New York City? You can really get confidential HIV testing at any emergency room. HIV testing is always confidential. We're not allowed to tell anyone anyone's HIV status by law, so that's protected. There's also some really great sexual health clinics through the New York City Department of Health. I've actually rotated at one of them, the Morrisania. Here we are. This clinic right here. I love this clinic. They have a really great model. No appointments are necessary. No insurance is necessary. You just walk in. It's kind of like a one-stop shop, honestly. It's really great. They can do HIV testing, PEP initiation, as well as PrEP services. So that's a great resource for anyone looking for all things sexual health. And then there's also the Bronx Care Health System, which offers mobile testing. I thought was really cool. And then we have the Montefiore Medical Center, Adolescent AIDS Program, Urban Health Plan, has multiple different locations, offers PrEP and PEP services. And if you'll notice, some of these sites offer both PrEP, the pre-exposure prophylaxis, as well as the post-exposure prophylaxis. Not all of them do. All of them will offer the post-exposure prophylaxis, but the pre-exposure is a little bit more selective, but still quite accessible. And this list is not exhaustive, not at all. I do want to focus on this PEP hotline. If you just have no idea where to start, you're kind of overwhelmed, you might be freaking out because you were potentially exposed to HIV, it's totally understandable. You can always call this 844-3-PEP-NYC and you'll have basically a conversation with someone, an HIV specialist. They'll start by taking a history, understanding a little bit about what happened, and then they'll start the referral process for how to get you tested and get you on the right track. So on the flip side, where can someone access PrEP? Again, a lot of those sites that I mentioned, they offer PEP and PrEP, but not all do. So I did want to highlight this Ready, Set, PrEP program. This focuses on the pre-exposure prophylaxis, and this is a federal program for people who don't have insurance, and it offers free PrEP for people who qualify. And what does qualify mean? They have to have a negative HIV test, they have to have a valid prescription from a doctor, and no insurance coverage for the medication. So with this, you will still have to get the testing, make sure you're HIV negative, talk to a doctor, get the prescription, but this will help you actually access the medication if you don't have insurance and are unable to afford the medication on your own. And then again, if you're overwhelmed, where do I start? Where do I go first? There's this NYC Prevention Sexual Health Warm Line, and their website is listed as well. It's like a soft intake. You have a conversation with someone and they'll start with the referrals and start getting you linked up to care. So when should we potentially start this whole process? PEP, the post-exposure start, like I mentioned, it's best to start it as soon as possible. Like, for instance, if you're having a sexual encounter, the condom breaks, pretty much as soon as you realize that you may have been exposed, that's when it's best to seek out care because that's when the medication is most effective. Studies have shown that the sooner PEP is started, the more effective it is at preventing HIV. But due to how the virus replicates, it must be started within 72 hours or 3 days to be effective. If you hit that 74, 75-hour mark, some providers may kind of fudge that a little bit, but once you're much past that, PEP is no longer really a great option for you, and it's time to talk about other treatment options. And again, this is about a 1-month course of oral medication taken every day, and when used correctly, especially when taken as soon as possible after exposure, PEP reduces HIV risk by 80%. And I do want to really highlight that this is an emergency use medication. The PEP, post-exposure prophylaxis, it's emergency use. It's kind of like Plan B, emergency contraception, and it's not a replacement for other prevention measures. So when should we start PrEP? Whenever you want to, really. As long as someone is HIV negative and they haven't been exposed to HIV, you can start PrEP. If someone is HIV negative, has potentially been exposed, you can start PEP and then transition to PrEP if you would like to continue to reduce your risk of HIV. Totally acceptable. But again, if someone does acquire HIV, PrEP is not really a great option for them. First of all, it's not effective at treating HIV, but it also increases risk of facilitating strains of HIV that are resistant to the medications that we do have. So someone who may really want to consider use of PrEP is if they routinely have sexual encounters without condoms, especially if they have multiple sexual partners or sexual partners that have HIV. If they have recently had a different kind of STI, because studies have also shown that STIs kind of run in packs. So if you have a history of chlamydia, gonorrhea, or syphilis, that does increase the risk of that person getting HIV. Anyone who uses injection drugs could consider PrEP, and anyone who exchanges sex for money, housing, or drugs as well could consider it, and anyone who might be planning to stop using condoms for whatever reason. So it's a wide net of people that could potentially consider PrEP if they want to.
Is it standard practice for you to get offered an HIV test when you go to the doctor and get blood work done?
It depends, but usually no. There's a couple of blood tests, HIV, hepatitis B and C, that for screening purposes for preventive care, everyone should get that done once in their lifetime. But if that test is done and it's negative, it's not like a routine annual thing. If the patient comes in, they're going for their well patient visit and they're like, oh, I potentially was exposed, I'd like to be tested, that's when we could consider it. But it's not like an every time you go, it's not like a CBC or cholesterol panel that's tested frequently.
Yeah. So it's more one that you would request and just say, I think it's a good opportunity for me to be tested.
Condoms, cannot sing high enough praises about them. They're relatively easy, they're cheap, you can find them all over the place. They're for free at the New York City sexual health clinics as well. So definitely condoms are a great way to help prevent HIV and other STIs as well. Transitioning away from HIV, talking about other STIs, looking at specifically gonorrhea, chlamydia, and syphilis, these are all bacterial infections, whereas HIV is a virus. I wanted to lump them together because this could be a whole nother talk talking about each one individually, but these infections are also transmitted by body fluids, most often by sexual contact. They can also be transmitted from mother to fetus or baby during pregnancy or childbirth process. So these are very routinely screened during pregnancy and right before childbirth because they can cause some pretty serious lasting impacts on the fetus or baby, and if severe enough, can cause pretty much lifelong health consequences. So these are routinely screened for anyone who is pregnant or nearing childbirth. They're also pretty routinely screened for during routine obstetrical visits. And also that's another one where if someone isn't due for their screening, they can definitely bring it up with their doctor and then screening can be done at that point. So speaking of screening and testing, this can be done at a lot of the same sites previously discussed with HIV testing. And these are done not through blood work, but they're done through what's called 3-point testing, or basically swabbing 3 different parts of the body where these infections like to live out. So HIV, that's a blood test, but these bacterial infections, they're screened for by swabbing the mouth, kind of like the back of the throat, the anus, and the genital area. So if we're talking about male genitalia, that's a urine collection to test the urethra for these infections. And then if we're talking about female genitalia, that's more a cervical swab. And again, to the point of condoms, these are quite successfully prevented by lifestyle choices. Pretty much the same lifestyle choices to prevent HIV. So that's routine condom use, using condoms correctly, using condoms often for all kinds of sexual contact, as well as limiting the number of sexual partners, talking with sexual partners about their STI status, getting tested yourself. So the lifestyle prevention methods are the same for preventing HIV and bacterial STIs. The treatment and medication prevention is a little bit different. So these are treated with an antibiotic, a short course treatment, whereas HIV actual treatment is lifelong. And depending on the bacterial infection, different antibiotics could be used. So it depends on what someone might have will determine which antibiotic they'll be started on. So really excitingly, as of I think just 2 years ago, a year and a half ago, research came out that we can prevent these bacterial STIs with something called doxypep. And doxypep is doxycycline post-exposure prophylaxis. So again, this is that same sort of PEP scenario where someone could be exposed, potentially exposed, or we know they were exposed to these bacterial STIs. And then we can offer them an antibiotic called doxycycline. So doxycycline, it's a very commonly used antibiotic, used often for skin infections, Lyme disease, any sort of tick-borne illness. It's used for a lot of different soft tissue infections. Very well tolerated, very well understood by the medical community, but this particular use of it is new. So how we would use doxypep to prevent acquisition of gonorrhea, chlamydia, syphilis within 48 hours of the potential exposure or known exposure, someone would take a 200 milligram dose of the antibiotic doxycycline just one time, and that will reduce the risk of chlamydia up to almost 90%, reduce the risk of syphilis, again, almost to 90%, and reduce the risk of gonorrhea by over 50%. And gonorrhea is a trickier one just because of the nature of that bacteria, but this is a really exciting new use of this well-known medication. And I particularly love this sort of prevention protocol because the practice typically is that doctors will give someone, say, like a 30-day supply of doxycycline, knowing that they likely will not use it every day, but they will have that medication on hand. So for instance, if they're exposed on a Tuesday 1 week, they take their 200 milligram dose of doxycycline, they're pretty much covered. And then if there's a potential other exposure before they have a chance to go back to their doctor, they have that medication on hand so they can take another dose of doxypep to prevent their risk of STIs. Going back to the tenets of harm reduction, it really empowers the patient to take control of their risk of infection by having the doxypep on hand. They can take it if they need it, if they're potentially exposed or if they are exposed. And these are really impressive rates of infection reduction. So it really helps to reduce the harm that can be associated with some behaviors. Patients typically acquire the doxypep prescription before they're exposed to the STI, so they have it on hand ready to go. And then if they are exposed or potentially exposed, they can take one dose of 200 milligrams doxycycline within 72 hours of exposure. The 72 hours is kind of pushing the limit of doxycycline's efficacy. Ideally, again, similar to HIV, PEP, we want to start this as soon as possible after exposure to increase the chance that you will not get gonorrhea, chlamydia, or syphilis. And people can take multiple doses of doxypep and it's safe, just taking one 200 milligram dose following each new exposure. However, if we do come across a patient who is taking doxypep 4, 5, 7 days of the week, that's when it's time to conversation about a different preventive method. This is really intended for intermittent, infrequent use, but if someone's needing doxypep more days than not, then it's time to have a deeper conversation. Even though doxypep does prevent bacterial STIs very well, it's not 100%. Nothing in medicine is ever 100%. So having this medication option on hand paired with lifestyle choices like condoms, reduced exposure, talking to your sexual partners and knowing their history, knowing your history, paired together is a really good way that further reduces the risk of getting these STIs. If you have a drug allergy to doxycycline, which is not uncommon, this is just not a good option for you. It falls within the tetracycline drug class. And unfortunately, usually if someone has an antibiotic allergy, we can swap things out. This is not one of those situations. Doxycycline is really the only antibiotic that's been studied in this setting. So if you're allergic to doxycycline or other tetracyclines, this really isn't a great option for you. So again, time to have a deeper conversation with your doctor. So some side effects. We know this very well with doxycycline. It does come with the risk of upset stomach, but that can be avoided by taking it with a large glass of water or food, having something on your stomach before you take it, and then potential for sun sensitivity. So wear protectant clothing. They have SPF long sleeve shirts and stuff now. Those are great. And then sunscreen as well. Interestingly, the current CDC guidelines only recommend doxypep for men who have sex with men and transgender women, just because that's the only groups who have been studied in the research. research. There are ongoing studies currently looking at other patient populations, specifically cisgender women, that have been showing some promising results. And theoretically, there's no real difference between these populations that would make me think that cisgender women would not benefit from doxypep in as high of rates, but it just hasn't been borne out in the research yet. I do know that the doctor that I like to rotate with, an infectious disease doctor, she sees no issue with prescribing doxypep to all comers. But again, the guidelines are written based on what's currently in the research. And then something more for the physicians, there's some concern in the medical community about antibiotic resistance. If we're using doxycycline more frequently, there's a potential that other bacteria that are also treated with doxycycline could be exposed to it more often and develop resistance to it. So again, kind of need to look at that a little bit more in the research and see how much of a potential impact there actually could be with that. Where could you possibly get this? A lot of the same places that offer HIV PEP or PrEP also offer doxypep, because it's a lot of the same sexual health clinics that we're talking about. So they like to cover all bases. Some primary care doctors also offer doxypep. Not everyone, so definitely like talk to your doctor. Some aren't comfortable, some aren't aware of it, some don't really know how to prescribe it, but it's super easy. So hopefully it will get more universal. And then Planned Parenthood, also a really great resource. And again, plug for the Department of Health sexual health clinics offered as well. That's just a walk-in clinic, no insurance needed, no appointment needed. You just show up and get your treatment. And then any sort of sexual health clinic in the area should be able to prescribe doxypep. It's kind of a hot topic right now. So if people don't have it yet, I am all but certain they're trying to get it. We're going to transition now to a different topic, but related to everything we've talked about. We're going to talk about intimate partner violence, or IPV. And unfortunately, if someone is subject to IPV, it can increase their risk of acquiring some of these infections, which is why I think that this is a good time to talk about them both together. Again, we're all coming from different backgrounds, different experiences. So if anyone feels uncomfortable or triggered or just doesn't really want to hear about this particular topic, definitely feel free to step out. I'm not here to upset anyone, just trying to provide information. What is intimate partner violence? Basically, this is any act of violence of a variety of types committed by one person against another. And this can be from a current partner in a relationship or a former partner. You don't have to currently be in a relationship for it to be considered IPV. It could be an ex or a long-term ex. But certain examples, not the entire list, of IPV include physical violence, more often thought of as like domestic violence, as well as psychological violence. So that's emotional abuse, threats, intimidation. And then there's sexual violence that lumps in with what we were talking about in the earlier part of the talk. And this is forcing or attempting to force a partner into sexual activity without their consent. And I'm a firm believer that consent is not consent unless it's affirmative and readily given. So even if someone's like, I don't know, maybe, that's not really true consent in my mind. So it's definitely a soft topic for people, but I think that consent should be really energetic and enthusiastic. And then IPV can also fall under stalking or repeated unwanted attention or contact that causes fear or concern. Someone's following you around, they creep you out, that can be considered IPV. And then there's also economic abuse, which is controlling finances, access to finances, resources, or employment. And unfortunately, this is quite common throughout the whole country. No one's really immune from the potential of IPV. And that's why it's really important to know the signs of abuse and how to seek or offer help. So this is a quick little video from the CDC.
Intimate partner violence is defined as physical violence, sexual violence, stalking, and psychological aggression by a current or former intimate partner, and is preventable.
Intimate partner violence threatens the well-being of millions of people and their families every single day. Intimate partners may include current or former spouses, boyfriends, girlfriends, dating partners, or sexual partners.
Intimate partner violence can occur between heterosexual or same-sex couples. Some victims may suffer just one experience, while others endure violence that lasts for years.
1 in 4 women and 1 in 9 men have experienced intimate partner violence in their lifetime. And 1 in 10 high school students have experienced physical teen dating violence, which is a form of intimate partner violence.
Intimate partner violence consequences are widespread.
It impacts physical and mental health. It results in billions of dollars in medical, mental health, and lost work productivity costs.
But the good news is that intimate partner violence is preventable. We have strategies that can help you prevent this problem in your community. We can prevent intimate partner violence by teaching safe and healthy relationship skills, engaging influential adults, working to prevent violence starting in early childhood, creating protective environments, strengthening economic support for families, and supporting survivors to increase safety and lessen harms.
IPV is unfortunately very common and affects millions of people in the US each year, including about 41% of women and 26% of men experiencing some sort of contact sexual violence, physical violence, or stalking. So just a subset of IPV even, and that's within their lifetime, according to data from the CDC. And that also includes over 61 million women and 53 million men experiencing some sort of psychological aggression by a partner over their lifetime. So a little bit different numbers, but goes to show that it impacts a lot of people. So if you know someone you're concerned about, you yourself might be concerned about, just know that this unfortunately is not a unique situation, but we do have a lot of resources available for help, to offer help, to seek out help, because it is so widespread, unfortunately. And often it begins early. Like that video mentioned, a lot of people experience their first incident of IPV before age 18, including something known as teen dating violence. It's specific to teens, highlighting the importance of early prevention efforts. And certain populations do see an increased risk of IPV. This is often due to factors such as social and structural inequities. A lot of different things within the community, not just unique to that person, could put them at increased risk of IPV. So again, lots of resources. The Department of Health has a lot of really great resources for people to reach out to, specifically the HOPE hotline. You can call this 311 number. I think it's between business hours, and go to a family justice center in the borough where you live. So they're all over the city, or where you feel safest, to get connected to additional resources, maybe get you to a safer location. And then there's also a 24-hour HOPE hotline. That number is listed there that you can call at any time of day. There's also a secure chat option. If you don't feel safe making a phone call, you can chat. Save Horizon, savehorizon.org/safechat. And again, they'll start the process to get you linked up with an advocate and make sure that you're safe and what the next steps might be. Another mode of communication, there's texting with an advocate with the New York State Domestic and Sexual Violence Hotline. You can text that phone number and they'll start giving you the information, start talking to you about what the next steps would be to get to a safe place. Thinking specifically about our Latinx population, we have this VIP Violence Intervention Program. It's another helpline. All of their operators are fluent in English and Spanish. This group is led for and by Latinx survivors of IPV. So this is a really great resource for that specific population. And again, we have the phone number listed there. You can call Monday through Friday, 9 a.m. to 11 p.m. And this group is great at helping getting people to safe places, helping with emergency shelter, and connecting people to legal counsel as well for how to get out of an unsafe situation. I really wanted to reiterate and emphasize that if there's concern for someone in your life or possibly yourself being subject to IPV, please know that you're not alone. Unfortunately, this is quite common, but that does mean that there are a lot of groups, a lot of resources that are actively working to combat this. So please reach out to anyone. Your doctors are also a really great resource, social workers, case managers, anyone within the medical field that you feel comfortable and safe talking about this with. They're another great resource to get linked up and get you to a safe place, get your acquaintance, your friend, your family member, anyone to a safe place, because IPV is unfortunately quite common, but it's not acceptable. That doesn't mean we have to live this way. So I just really want to emphasize and reiterate that resources are available. Even if you think the situation is really sticky, really hard, that first step is making that phone call, sending that text, sending that message, just reaching out for help. And then from there, one foot in front of the other. We have come such a long way in just 30, 35 years, but I do also want to point out that that did not come easily. Patients, advocates, community members, community leaders fought tooth and nail. Literally, some of them laid their lives down to make those steps. Being Pride Month, I really want to acknowledge the work that a lot of our members in the LGBTQ plus community did so that all of us could benefit from that. So we have come a long way, but it was not easy.
I think sometimes it's easy to look at the past and think that this sort of trajectory was inevitable. It's like this took tons of work, patients and doctors and so many people. And I just want to note too that within the current administration, we're trying to keep that research going. as much as we possibly can, keeping that in mind as well. In terms of IPV or abuse, people can make false claims of things like rape. I just wanted to address that and say it's really important that we're always believing survivors and we're believing people's stories, no matter what. It doesn't matter if it's 10 years after something happened or 100 years after something happened. I think a lot of times we're fed sort of disinformation about how common things like false allegations of sexual assault or something like that are, and when the incidence of that is pretty much nothing. So just wanted to throw that out there as another thing that we can talk about in terms of harm reduction, is that we're always believing the person whose experience it was.
I am also of the mindset that I would rather pursue and chase down a false allegation than ignore 10 real ones, because that impact is literally lifelong. So I agree, false allegations, rarely they do happen, but I would much rather listen to what someone says, see what the case may be, than just chalk it up to someone's telling a fib, someone's telling a story, because there are far more instances of people not speaking up. Sexual assault, sexual abuse is way more common than is reported because of the stigma. People don't talk about it. People don't want to report. People don't seek out care. And sometimes people don't even realize what happened to them. It can come years down the line.
What happened.
The case of underreporting is far more common than false allegations.
The idea that false allegations are common makes it so people don't want to report it because they don't think they'll be believed.
Exactly.
That is the last thing we want. We want to make sure that everybody knows that they will be affirmed and believed, and that the incident will be investigated. We're talking about things that get investigated and go to court, and that's often not fair either. But there's a process here. So you believe to start with. If somebody reports something, you believe their story. So just to underscore that.
Exactly.
It's an important part of harm reduction too.